So I will start with my lecture about lung ultrasound with a case. So it's a patient, 60-year-old, female. She's lying in intensive care unit, and she has a COVID infection. She's doing really badly, and she developed acute respiratory distress syndrome. So it's the standard patient for me that I get early in the morning to compare the examinations, to talk to anesthesiologist, and to try to figure it out whether something is better in her condition, something is worse. So, and the so X-ray looks like this. So there are multiple shadows. I cannot say whether there is pleural effusion or not. Hopefully, I will have for examination, and I will stick to it. Yeah, nothing has changed since the last time. So it's the best that I unfortunately can. There are multiple questions that anesthesiologists would like to know. Is there a pleural effusion, pneumonia, pneumothorax, pulmonary edema? And I will just say, yeah, maybe nothing has changed. That is good information, for me at least. So we need something that is really easy to do, and some method that will show a little bit better how is this patient doing. And with the involvement of, so availability of the ultrasound machines, there are numerous machines in intensive care unit now, so they are not missing, and almost every room or every bed has ultrasound machine. And when somebody knows how to handle it and can perform the examination, can answer on all of these questions. So what do we see here? So this doctor made examination in this patient. So he's lying or she's lying on her stomach. So it's typical for really advanced COVID patients in really bad general condition. And we are seeing this. So we are seeing multiple baselines, and we can say, yeah, in this part of the lung, the most prominent finding is interstitial thickening. And it is saying there is two things. We can say there's pulmonary edema or there is fibrosis. So the patient is acute ill. That means it is probably interstitial edema. So we have two options. We can do portable radiography. So our radiology technologists are going all over the intensive care units, all over the hospital, and trying to do these radiograms in really, really bad conditions. So I don't know, have you seen how does radiography in intensive unit looks like? So the one we saw, it's the perfect, the best option, so the best conditions as possible. It's usually not like that. We don't see nothing. We can see maybe, so where are the lines, where are the tubes, and all of these questions are really, I don't know, maybe. So a study, so this perfect study, really good performed study, compared these two examinations, and it comes to the conclusion that really lung ultrasound is more sensible and has more higher specificity in answering to all of these questions. And what is really not so good, it's devastating, sensibility in detection of, for instance, pleural effusion in pneumothorax is lower than 50%. So there is a 50% or more chance that I am not going to see these two important things in chest radiography. And for instance, pneumothorax can be when big, and there is tension pneumothorax is life-threatening. So I'm really bad at it. So let's say about some ultrasound. So it's mostly artifact-based method in all in other body parts. is like direct visualization, but in the lung, we are looking at artifacts. So we have two A lines, typical for air-filled lung, B lines, they are happening in thickened interstitium, so pulmonary edema and fibrosis. Advantages of this method, as you all know, so ultrasound, radiation-free, low-cost, rapid, portable, real-time. Now, this bedside ultrasound in emergency is a standard care in intensive units. And what is the most important for this small patients? So the pediatric patients has a small diameter of a thorax, and with our proper convex transducer, we can go really deep inside of the thorax, and we can also without problem look at the vascular structures in the mediastinum and heart and everything else that is there. So for instance, this is option for one squiggling kid. So it's called Pigostat. So Mr. Pig is really radiology assistant in Texas. And he came up to this idea that he tried to immobilize these squiggling small kids. And there are all sorts of these immobilization devices for these kids. So I don't know, is it comfortable or not, but this kid is really scared, I can say. So when you can choose to perform ultrasound in a kid like this and get more information, I would always use an ultrasound. And not to say guiding interventional procedures, you tried yesterday, so you can do everything. Limitations, operator dependent, you need around 20 minutes to perform ultrasound of the whole lung. And the findings you see are seen in variety of conditions. So you need to choose really good your transducer, because the visualization of the abnormalities is just below the pleural line. So we are trying to go deep as we can. And as I said, so we don't see Lysen tubes, which we see in radiography. So choose your transducer. You can do it with all of them. Which you have, you can use it. So we are going to look at the lung in all of this anterior, lateral, and posterior position, and we are going to scan it longitudinally and transversally. Optionally, when we have time, money, I would then try Doppler first, and when we do some research on something, or our department has money, we can do also contrast enhanced ultrasound. So let's go to the physics. So A lines look like this. I will talk about it more. B lines look like laser-like strikes, and consolidation is like every consolidation. So it's the normal lung, as you remember from yesterday. So we have here running ends, and normally up to 2 B lines are in normal lung, normal to see. Okay, we have A lines, so this reverberation artifacts that are going deeply into the lung. Pulmonary edema, on the other hand, predominantly we see the B lines, so laser-like structures. And here is the case of lobar pneumonia. This is not a liver, this is lung. Okay, it's called hepatization. So there is no more air in the alveoli and bronchi. There is just infiltration with cells. Something more about every characteristic of this ultrasound. So we have air-filled lung, typically A lines. So I draw this on the line. So there are numerous A lines. They are horizontal reverberation artifacts of the hyperechoic pleural line reflected from the air-filled lung. Okay, it's logic. But problem is that we also see in asthma, obstructive pulmonary disease, pulmonary emboly without infarct, because infarct is consolidation, so we can see it directly. And in mild viral infection, I said also, so up to 2 lines are normal pro-intercostal space. Pneumothorax, we went it through yesterday, so there are no running ends. B mode, we see this barcode sign, just reverberation, artifacts of pleura, and schematized. One more comparison on the left side, seashore sign. So we have lung, pleura, and thorax, subcutaneous tissue. And in pneumothorax, we see underneath the pleural line just the artifact. Second thing, interstitial thickening. So it is characterized with B lines. So there are here well-defined vertical echogenic lines arising from the pleural line. So important is to note that the number of the B lines correlates with the disease severity. So when we objectivize something, we can follow it. So when our patient is doing better, so inflammation values are going down, we are going to look at this ultrasound, and we will not see so much B lines, but for instance, 3. So he's doing better. We can objectivize it. So pleural effusion, we talked about it also in AFAST. So anechoic fluid in the posterior dependent lung. We can measure it, volume estimation, diaphragm, lung distance times 20. And what is really important here, so there are no more artifacts due to air-filled lung, and we see without a problem, so these structures in posterior mediastinum, for instance, aorta or spine. So it is called spine sign. This pleural effusion can make a little trouble for us. It can be complicated like empyema. And we see the structure like this above the diaphragm, so solid structure with multiple fluid-like parts. Out a Doppler, we don't know whether it's probably a neoplasm. It can be. So we are going to look into our Doppler images, and there is no vascularization inside. Sometimes when there are air bubbles inside of the empyema, we can look at twinkling artifact, but it is not so important now. So infection, different imaging appearances depend on consolidation or interstitial involvement. So we have hepatization. We can have not going to do and order some expensive examinations. We are going firstly to try to evaluate the pretest probability of deep venous thrombosis. And we are doing it by looking at the Wells score. So we need to talk to our patient and not immediately send him to CT, so pulmonal CT, to try to exclude the pulmonary embolism, because it is happening every day. And everybody's thinking maybe when he has here, but no, we need to do it in right order. So first talk to your patient and try to determine, regarding clinical features, try to make this scoring and try to see how much is it. So more than 2 score or same as indicates that probability of deep venous thrombosis is really likely. And when lower than 2, so deep venous thrombosis in this patient is really unlikely. When we have still a patient that has this swollen leg, in this situation, due to a patient's condition, I'm going to order some laboratory. So I'm going to do this. So high sensitivity, so D-dimer values. Okay? So then we are doing further laboratory findings. There are 2 things that we can do. So when you have time, whole time in the world, 1 hour, for instance, we do this one, complete duplex ultrasound. So because it is the preferred venous ultrasound test for the diagnosis of acute deep venous thrombosis. So we are doing really thorough examination of the whole leg. And we are doing the compression in 2 centimeter intervals, and we are doing the Doppler examination and everything. So, you know, I said it lasts up to 1 hour. So it's really not so realistic to do it in emergency department. And so there is option on the left side. So this limited protocols. What is a bad thing regarding limited protocols? We are not 100% sure whether there is deep venous thrombosis or not. And especially because we are not looking at the calf veins. And this study requires a second study in about a week to safely exclude DVT. Problem with D-dimer is that it is not specific. So when we have high D-dimer values, patient had probably yesterday sport, or patient is obese, or there are really many things that can make this D-dimer a little bit higher. So we are really not so good enough in specificity. So then we can decide, okay, I will do my point of care ultrasound, because there are not a lot of us that can do today in my department. So everybody has COVID and are sick. Or I don't have enough time because I have 50 more patients in the ambulance that wait. So we are going to do this one. So extended compression ultrasound. We are going to look at the common femoral vein. Then we are going to do compression of a femoral vein and popliteal vein. So that should do. What is not to forget that there is a typical appearance of the veins, and we really need to look at the veins and do it actively. So active compression. Sometimes the problem makes a patient is a little bit so is obese or leg is swollen, and we cannot compress it enough. But try to compress it enough, because when you do this and you see that the vein compresses completely, there is no thrombus inside. Venous thrombosis is shown with dilated vein, with hypoechoic thrombus inside. And when we do now not compression like this with full energy. So we are going to really take a small compression and try not to push this thrombus up to the heart. Okay, when you sit this, we are going to be careful. Okay. when we see the thrombus in vein and we look a little bit above the inguinal ligament and we think that there is iliocaval disease also, so we are then going to do the CT firstly and MRI who has money. So we don't do it normally in emergency. So we do CT. When you write your report, there are 3 things you need to at the end to summarize. Is it acute venous thrombosis, chronic post-thrombotic change, or I don't know, it can be, so like in this image, so there was an old DVT and the new thrombus came. So that's it. And I will show you just in shortly how I do it. So we have a model here. Ist eingeschaltet? Hm? Ja, dann langsam ziehe das nach oben. Ja, hast du Tucher oder ich kann die? Hast du einen Tucher oder ich kann einfach, du kannst, ah, das sind es. Okay. So here I will use this linear. Usually there is a transducer with a higher frequency just for vascular ultrasound. Usually I will do this examination so patient is lying. Or for instance, when we are looking at the popliteal vein, patient can lie on the side, on the left side or the right side. So it is really, every position is possible to take. So we are going to this one. So it's convex. This one. Vein. Okay. Okay. So we are going to visualize our Mickey Mouse, as you all know. So we like to connect it, so to make this mnemotechnic really good. Or you can also use this Ivan mnemotechnic. So the vein is always lying of an inside vein arterial nerve. So we are going to optimize a little bit our image. On the other side. So adapt the depth a little bit. So you see, so the common femoral artery here. So you see the common femoral vein, and great saphenous vein is here. We can use it like just to test it. We can do this, and please take a deep breath in and don't breathe. And we are looking that there is also only pulsation in the artery and no in vein, and please breathe. And now we can confirm it. So I will do it further in the B mode. So I will then compress this vein. And when compresses completely, there is so no thrombus. I will do it gradually up to the, like this. So in vein ultrasound, you need a little more gel. So we are going to do this compressions up to the adductor canal here. And then I will say to my patient, okay, you can flex your leg or you can lay on the side, and I'll do it like this. So one more time. So superficially is here the vein. So I'm doing transversal compressions from inguinal ligament up to the knee. And when I see something, you can stretch it out. And for instance, when I see something here, I will then use my longitudinal. Okay. I can do also when I do Doppler examination, I can also, when I don't see any flow, I can do a compression. And you see how this flow is more and more coming up. Okay. So today you're going to train this thing. So thank you. And if you have questions, please ask. Thank you.
So, does anybody of you have a question? Yes?
So when I have a patient that doesn't have anything, I can look at this leg, for instance, so in 5 minutes. When the patient has body mass index 35, the leg is swollen. So you know how it is to touch this leg. You cannot compress it. And you are really fighting in the calf area to compress something. And we really need to be precise because we need to say, okay, there is a vein, thrombosed vein. I'm not sure whether patient in history had thrombosis in, for instance, 2 years ago. And we cannot say whether this is a new one or old one. So it is always taking a time. And when you have time, use it. I can do it really quickly. It's not a problem. It's also like eFast. Just think of compression and looking really and saying yes, no. But if you want to look at it like every vein, so it's like, worst case scenario. So 1 hour. Okay.
Okay, can we get a microphone for the ones that ask questions? I'm a little bit afraid of repeating them. Yes. Does anybody else have a question? Okay. Somebody from the online audience? Okay. No questions. Then I have a question.
Yeah.
Do you have any hint for how to remember which artery and vein can be found where best? I mean, we already saw one sign in your
So
presentation.
it's perfectly shown in anatomy and everything. Then there are rules or something like that. But for instance, for poplita, so fossa poplita, the anatomy, they don't say that the anatomy is really going not only from left medial from lateral, that is going in deep also. So as you have seen, so here is the vein is a little bit medially lying, but really above the popliteal vein, so some artery. So sometimes it looks like these two structures are in the same line. So for inguinal region is simple. It's this mnemotechnic IVAN. So inside vein, artery, nerve. But for poplita, it's a little bit complicated. It should be that is so vein is medially than artery and nerve, but as you have seen, so it's not really in reality like this. So you can do always when you have problem, try to compress the structure. So usually compresses only the vein. The artery will pulsate, so you will see this small pulsation when you don't do the Doppler examination, and all of the anatomy of the calf is always the same. So there is 2 veins always following the main artery. So there are 3 major arteries, so tibialis anterior, posterior, and peroneal or fibular. And there are 2 veins. The problem on a calf are muscular veins. They are so different. So really for the vein system, So there are no really standardized, so deep veins, muscle veins, just the big ones. So when you see, try to compress it. Okay, so there are no rules for these other locations.
Okay, then thank you very much.